Yeah. They had like equal representation. All right, I'm going to close this so the other session can set up. Bye. Hi, Barbara.
Unmute, no video. There we go. Hi, how are you?
Okay, good to see you.
Good to see you too. Everything okay?
Yeah, there's I'm gonna make you a co-host. So you have.
And I just talked to Jennifer. She's going to sign in, and Edgar's signing in. So.
Okay.
Edgar's actually the person he needs to be. He's the person that's managing all the slides and stuff. So.
Okay, great.
How's it going so far? Okay.
Yeah, I think it's been great. Been like at about 70 people.
Yeah, good. Maybe next we'll actually get to do it in person.
Oh my God, yeah, big party.
Let me tell, I can tell them. You can probably hear me because I'm in the room right now. So for folks that are just arriving, we're having some technical issues and we're trying to figure out the hosting. So let me just.
John Sanchez is the host and I'm the co-host.
Okay. So JP, if you're in this room, can you make me the host? JP is not. Let me call Nelson. Hello.
Hello.
Just call Nelson. We have some time.
Yeah.
I think regardless, we're good. I just am concerned that if John Sanchez is the host and they're not seeing the people entering, people need to be admitted.
I can see, so I can keep adding people if you'd like.
Okay. Yes, please do that.
Okay.
Hey, so John Sanchez is the host in my room. Can you make me host? Because my presenter is actually admitting people for me. Please make me host. And then I'll make sure that multiple people can share. Yeah.
Your host
good.
now.
Okay, thank you. Thank you. Okay, so I can admit people now, and then you don't have to worry about that as people pop in.
Great.
We're in a break right now, and we've been going like all morning, so everyone's doing bio break and all that. So
Totally.
you look good. It's good to see you.
Thank you. I wanted to say that all of your practice of doing your own haircuts all year, you've really gotten it down.
I'm getting really good. People are like, did you like start going to see a barber again? I'm like, no, it's a barber called Anthony. You know what I love about it actually is the convenience of deciding whenever I want to have a haircut and doing it as often as I want to.
Oh, yeah.
So I actually cut my hair every 2 weeks now.
That's great.
And yeah, it's been working out. I have a little, I can show you if I turn. So you can see my slight
Oh,
bald spot.
nice. Look at that cute scar. I like it.
Yeah. So I'm working up like sort of the story behind it. Or like when I meet people, people be like, you know, how did you get that? I'll be like, I had brain surgery.
I was
I had a brain
saved a baby
transplant.
from a bus.
Aliens abducted me and they
And that's
stole
what-
my brain for part of it.
Mhm.
There's a chip in my head. Or I really want to use this one. It's like, that is not a good idea. Do you know what I need? Your bad ideas, like I need a hole in the head. And I already have a hole in the head. But I haven't quite gotten there yet.
There will be a time and a place, but you should hold on to that one.
Yes. So Lourdes and Jocelyn, while we catch up, so Catherine and I have known each other for a very long time, and so I apologize for our banter, but we have not seen one another in a while.
No, it's been a while.
I know, since I left.
It's been
Actually,
almost about a year. When did you left in the summer, or was it?
I left in the summer.
Yeah, the summer.
I left in the summer.
We were at the COVID
Well, like
right now,
summer.
a year ago.
I worked my last callen lord shift in August. So
Okay.
yes.
Yeah. Oy.
Yeah. How's Brooklyn?
Oh my, honestly, it's amazing. You should
That's
come
what
back
I
to
hear.
your DM here. Love all of the sites, but our site is the best.
So AV actually contacted me and was like, hey, like there's this triage role that you can do remotely. And it was kind of, and I said, no, I'm really busy. But I told AVS, like check back in with me because who knows, you know, I might have some bandwidth that may not be. Oh, thank you, Jocelyn.
Yeah, Jocelyn, you can do it. 3 weeks, you got it.
You can do it. You can do it. And it's like, this is the point at this conference because it's to help you to take a step back from all the stuff that's in front of you and to realize that the reason why you're doing what you're doing is because you can make a profound and massive impact in the world and queer health. So
it's also always nice
so
to
I
see
find
people that survived it and know that you will as well.
You will as well.
Yeah.
These are wise words. So, but thank you for for that, because honestly, it's like I've gotten kind of used to the whole Zoom thing in terms of connecting people, like, you know, reconnecting with people and seeing people, but it's especially when it's someone that you really, really want to see. You're like, oh, it's so good. It's so good.
Yeah.
The universe is right. It's good. Wait, is this your, this is Brooklyn then? You're in callen,
So
Brooklyn.
I'm speaking to you from one of the consult rooms.
Oh, fancy.
Hmm.
I see your Keith Haring artwork in the
Yeah, we
background. That
We
was
got
very thoughtful.
over 140 limited edition posters.
I love it.
And so they're all over the place.
Did you guys get those from the foundation? Like, that's
They're-
amazing.
Yeah.
That's amazing. I'm just so beside myself proud of you.
So they've been so amazing. They've been so great, so supportive. It's really a lucky relationship.
Yeah, well, it's not, I mean, as my mother says, as an Asian mom says, you make your own luck.
Exactly.
Because I always say that to her, I'm like, oh, I'm really lucky, mom. And she's like, no, you make your own luck.
I would agree to that like I made my luck in being at callen Lorde at the right time.
Yes.
But I think callen Lorde made their luck with the Keith Haring Foundation, and I'm just riding that one. Yeah.
That's true too.
Yeah.
All those things can be true.
Mhm.
Yes, all those things can be true.
Yes.
So I'm hoping, so we had this issue, and I'm worried now because we had this issue with the links that were in the program, and I have a funny feeling that it's going to cause some confusion. But yeah, so because yeah, we can give it a few minutes, and I mean, you have an hour, so I'm not worried in terms of this, but I'm just kind of like, what happened with this? We've had some technical issues today, as we always do on the first day.
It happens.
It wasn't it's better than it could have been. So like, so it's okay. I'm okay with it.
Totally fine.
I've just had a lot of late nights with all this and life.
Yeah. I like the background for the conference this year.
Oh, thank you.
This is last year, right?
Yeah, we have a designer that we work with who we pay them, but they practically volunteer their time because they do a lot more work for us than they're getting paid to do. And they're at Memorial Sloan Kettering.
Oh, that's cool.
And they come up, we give them the idea and a concept, and then they mock stuff up. And this year they came out with this kind of cool
Rainbow person.
little person that's like breaking out, and resilience and innovation was our theme this year. So it kind of like fits in with that. So I'm happy with that. It's really nice. It's like, it's kind of like it takes a village, and people have really contributed over the years. Yeah, I've been involved with this conference since its first year. I was a presenter its first year. So 9 years. Isn't that crazy?
A long time. Yeah.
A long time.
What was your presentation the first year?
It was about LGBTQ education within the residency program how do you do this in the residency program as an exemplar at Weill Cornell when I was there. So, and that's how I met Nelson, who's one of the co-directors of the conference, and the rest is history. And I have to tell you, Catherine, like people don't know this story, but I met one of my current bosses at Stanford, the PIs that I work with now, at this conference years ago. And it's because of that sort of chance meeting and them talking about the Pride study that I work on now that I had a collaboration with them during my PhD and met the other co-PI and collaborated with them, and then have a postdoc with them now. So, and that was because of this conference. But it wasn't because I was being strategic. It was because I was feeling very passionate about LGBTQ health and just kind of devoted my time to things that I cared about. So.
Yeah. And then like
Andrea, is everything? Oh, I'm sorry.
That's good.
Hello, just checking in, making sure that
Everything
everybody's
is
okay.
good. So my concern is, was there an issue with the links, like the Zoom link that's in the program?
Yeah, so we're gonna get that fixed. I'm gonna get everybody ushered into.
Great. Okay, so we will have.
So we've already started that process. So I just want to
perfect.
Make sure everybody's okay.
So we might start just a couple minutes later then, because I will.
Okay. Yeah, and everybody just got situated in the other concurrent session.
Great. Thank you.
So I'll pass the word along.
Thank you.
All right. Thank you. Thank you, everybody.
So yeah, so it's nice when you do the right thing and the universe does the right thing. But it kind of worked out well for me.
Totally. Well, you made your own luck.
That's true. Exactly. So let me look at this. So your session during this slot from 2 to 3 p.m. Eastern time has another session as well. And the problem was I think the link is wrong in the program for ours. So like I'm hoping that this happened in our last session. So when we were doing the poster Q&A, but we just shuttled people over and it all worked out in the end. So as people are joining, so welcome Christian. We had a little snafu with our Zoom links. So I appreciate everyone's patience as we get set up. And I am admitting another person who is from UCSF, who I know actually. I'm gonna say hello.
I mean, it's already a successful party. You just need a few people.
Exactly. So Catherine, if you want to actually, do you have the capability of sharing? You can open up to your first slide maybe, and then people can see that.
Totally.
You should have the ability.
Mhm.
Awesome.
Let me just-
Awesome. Perfect. And perfect. That's awesome. It's beautiful.
Yeah, I love our pictures.
We have some good pictures.
Yeah.
So welcome, Matthew. It's nice to see you online. We're just gonna, as folks come in, we had a little issue with our Zoom links and people are being shuttled over from the room that they were in probably and to where we need to be. So if everyone will bear with us, we'll get started in just a couple minutes here to give some time. Yes, I see more people. So welcome, Marcus.
Hi. I have to leave for another meeting at 2:30, but really looking forward to hearing some of it. Thank you.
No worries, no worries. And I think I'm going to speak for Catherine to say that they might be willing to share their email address if you had a follow-up question or something.
Yes.
So if you want to put that in the chat, Catherine, that'd be great.
Thank you.
Because this is a fabulous presentation.
I mean, I like it. I think it's a good.
Yes, we'll just give it a couple more minutes here while we get more folks over. Thank you, Catherine, for sharing that.
Mm-hmm.
And I'm going to open this. Make this smaller. So while we're waiting for folks that have been joining, I'm just going to mention to you all that Catherine is not only a former colleague of mine at Callen Lord Community Health, but also a great friend and a great nursing champion as well. The world of nursing is a small place, and it's really, really wonderful to see folks like Catherine that are leading the good charge in terms of queer health and doing the hard work, quite frankly, that's unsung and sometimes thankless. But I appreciate you, and I have always appreciated you, and this is going to be such a fabulous presentation. I'm so excited for you to share your good work. So as people are coming in, so Andrea's coming back in probably to check to make sure everything's okay. Let's see. Hi, JP. Thank you for joining. Hey, Andrea, is everything okay?
Yes, just making sure everybody's okay, you know.
We good. Folks have been coming in, so it looks like yes, things are happening to get people over here.
Okay, all right, perfect, perfect.
To admit. Do you have folks in your other room as well?
Yes, yes. So just trying to, you know, make sure that everybody's aware.
Awesome. Okay. So I'm actually, as we're waiting here, I'm going to do your intro, Catherine, so that we can kind of start to get started. Cool. So thank you for everyone that has attended this session today. It is such a great pleasure to introduce my friend and colleague, Catherine Chisello, who's a scholar and educator, and I'm going to read this because it's so well written, who is deeply committed to health equity and social justice. She has participated in humanitarian work since 1997 in countries around the world, including Nicaragua, Mexico, Nepal, Ghana, and in disaster relief efforts in Puerto Rico after the island-wide devastation of Hurricane Maria. And Catherine spent 7 years working with undocumented and uninsured communities in Queens, New York, where she provided full family care, including pediatric and adult care, and managed a low-risk OB clinic or obstetrics clinic. When she started at Callen Community Health Center, she became an HIV specialist, and I'm admitting some more folks here while I do this, and focused on serving the LGBTQ plus communities. Recently, she oversaw one of the health center's most valuable programs, which provides same-day, free, low-cost sexual health primary care and HIV medical services to those with medication adherence issues or who have been lost to care, often because of coexisting substance use and mental health concerns. In addition to her clinical work, she is the director of the Keith Haring Nurse Practitioner Postgraduate Fellowship in LGBTQ plus health. The fellowship is the first of its kind in the United States, and its inaugural cohort started September 2020. Through this fellowship, Catherine strives to create an educational and training program that allows the Keith Haring Fellows to bring forward all they learn to other healthcare settings, thereby reducing the healthcare disparities for LGBTQ plus communities, and also uplifting and supporting nurse practitioners, especially those new to practice. And I want to mention personally that Catherine lives in Brooklyn, New York, and is an adjunct faculty at my other academic home, NYU Rory Myers College of Nursing. So welcome, Catherine. You've done some phenomenal work here, and I'm so excited for you to share with us what you've been doing with the Keith Haring program. So take it away.
Thanks. I'm so excited to be here and to talk about this program. Obviously, it's near and dear to my heart, and hoping today can leave you with some ideas on some things that you can do about training future nurse practitioners as well. So let's just jump in and get started. So objectives today will describe the development of a novel nurse practitioner fellowship in LGBTQ health. We'll identify some specialty areas for enhanced mastery of skills and knowledge related to LGBTQ plus health, and we'll discuss the first year progress so far and the preliminary lessons that we're learning of our first of the first year through our fellowship program. Please, if you have any questions at any time, feel free to put them into the chat. Anthony's going to kind of moderate the questions, and as big ones pop up, if happy to be interrupted and chat. And also I did put my email in the chat, so if you need to leave or you want to reach out to me for more information, please do. Always happy to talk at a future date as well. I have no relevant financial relationships to discuss, and I'm not going to be talking about any medications or therapeutics. So Callen is pretty well known in these parts. If you're not from New York City, Callen is a federally qualified health center that specializes in offering LGBTQ services and HIV management within the realm of primary care. You walk in, you get everything you need. Of course, we see anybody and everybody who comes in our doors. We just happen to focus on LGBTQ plus populations. We've been doing it now for over 50 years. And it's amazing. It's a really special place. If you're ever in New York City and you want to drop by just to take a tour and walk around, highly recommend it. You're always welcome. Something that I think is really special to note is that every picture that you see on this slide and the future slides are all pictures of our patients or our staff. We always make sure to represent our community with our communities, and it's a really, I think, special extra touch. This is a little bit of a timeline about our history. I'll go through it briefly just in case people are very familiar with Callen, but we started in 1969. It was actually a group of physicians who got together, noticed that these communities weren't getting care, and just met once or twice a week at this kind of downtown West Village location, almost like an apartment, a community area. It wasn't an actual clinic, and they would just start seeing mainly people who were suffering from substance use disorder or sex workers who were embarrassed or uncomfortable going to other clinics, and the lines would just start wrapping around the block. Eventually, they moved into a second or third floor of a community center, not a community health center, but a community center, put up some makeshift walls, started seeing patients in exam rooms, and from there, they started combining, partnering with other community groups, like the Gay Men's Health Project and the Women's Health Collective. Eventually, they did open up their mainstay on 18th Street, and then expanded to a mental health clinic on 17th Street. This is all in Chelsea, Manhattan, and then opened a clinic in the Bronx in around 2016. In 2020, we opened up our clinic in Brooklyn, and also with that, the Nurse Practitioner Fellowship, the Keith Haring Fellowship, which we'll talk about right now. So first off, why develop a Nurse Practitioner Fellowship or residency? And also just a little vocab lesson. When talking about nurse practitioner postgraduate training programs, fellowship and residency are used interchangeably. And why is that? Because the governing bodies of these programs don't really care which you use, just that they want to support you in creating them. So some places don't like to use the word residency because it's too closely associated with physician training. Some places like to use the word residency because they actually put their nurse practitioner residents in a similar program with the physician residents, and it's just easier for them to keep all those learners or skill developers all in one place. Other people really like to use the word fellowship because it's a postgraduate training program. So nurse practitioners are expected and allowed to do full clinical practice at the completion of their degree. So adding on this extra year of training becomes more of a fellowship. It's a specialty aspect of training. We use the term fellowship for our program for that reason, because our program is primarily solely focused on LGBTQ+ health, which is an aspect of training that you don't get in any of your programs, medical, physician assistant, NP, or otherwise. So we consider this an add-on year to develop skills in a specialized aspect of care. But so why develop these? Because the nurse practitioner workforce is growing ridiculously in an amazing way, but is so huge and gets bigger and bigger every year. And that leads educators and leaders within healthcare to kind of consider about the healthcare setting we're throwing these people into. Are they getting enough training in complex patient care management? Are they understanding the true delivery of healthcare within the system they're entering? Questions like that. Some proof to the pudding, NPs are projected to increase by 93% between 2013 and 2025. In fact, in the year 2016, 127,000 nurse practitioners graduated from their program. There are currently more than 270,000 licensed NPs in the US, and this is from 2019. 126 of those were just from 2016. So to think about that, we're probably double that number by now. 87% of new NP graduates are educated in primary care, with 67% certified as family nurse practitioners. And 83% of full-time NPs accept Medicare and Medicaid patients, and 80% Medicaid patients, which can lead you to believe that they're seeing some of the most vulnerable patients and in the most need of healthcare. Furthermore, it's a recommendation from the Institute of Medicine. So in 2010, they published a report outlining the need to develop programs like this, and then only came back 5 years later to say, yeah, we still recommend it. This is still something that's needed and something that we believe in. Really what they're wanting, what they're recommending are programs that help the transition from learner into full-time provider, which I think we can all understand is a really big step and a big change in a person's career. Not everybody loves the idea of these programs though. The Nurse Practitioner Roundtable, which is a group of, I think, 9 professional nurse practitioner groups, published a paper in 2014 stating that because our nurse practitioners are so well trained in their programs and we have all of these years of results and experience backing this, they don't need these programs. They're fully trained, ready to go clinicians. This kind of training and these fellowships and residencies aren't needed. However, some research is now suggesting that the difficult role transition that happens from learner to provider makes these programs actually very helpful and very necessary. what do the NPs think? Do NPs think programs like this are important or needed? So in 2017, Weizmann did a survey of already practicing NPs that found that many would have thought a program like this would be helpful. 66% of the respondents acknowledged that they didn't know all of the things that they needed to know to feel successful and competent in their first year of practice. And also a skills gap, that they hadn't practiced all of the skills that they needed to be successful in their first year of practice. They also reported a lack of mentoring, the need for further clinical decision-making and coaching, and the need for further practice in prescribing, billing, coding, which are things we usually do tend to learn on the job. So when did these programs begin? Where, why, by whom? This all started in 2007, so they're still relatively new programs, not even 20 years old. And it started with Margaret Flinter in the Community Health Center Incorporated in Connecticut, which is a large system of FQHCs in Connecticut. They have many, many clinics, many, many providers spread throughout the state doing amazing work with communities in need. And Margaret Flinter noticed that a lot of the new grads coming to this organization were really struggling and not even staying because they were having such a hard time. And so she actually bottom lined and started the first nurse practitioner residency for new grads only, to learn how to manage, you can say, complicated patient populations that were in a lot of need of a lot of healthcare. Take it forward to 2020, there's more than 80 organizations now in the United States that have residency and fellowship programs across the country. And these are in academic health systems, such as teaching hospitals, community-based practices, federally qualified health centers, and there's also a large one in the Veteran Affairs medical centers. Keston et al. Actually has done a lot of work evaluating these programs, and at one point did a survey of all 88 programs in the 32 states. As of 2019, there is obviously more because we were not counted, so there's at least 89. 49 of the programs responded, and 41 of the surveys were complete. So of these 49 programs, 41% consider themselves residencies, 51% consider themselves fellowship. Like I said, personal choice. 5% consider themselves postgraduate training programs, which I think is a really interesting way to term it, especially to call it, especially if you want to include other professions such as physician assistant, such as physicians. Most of the programs are 12 months long, 12 months in length of time. Small cohorts, the largest being 20, which as a current director of the program, I cannot imagine having 20, but it does exist. 73% of the programs are not accredited, and we're going to talk about what that means and if that's really recommended or not. FNP is the most common, and most of the programs are primary care focused. So here's a map of, as of 2019, where the nurse practitioner programs, postgraduate programs lie. So you can see that, are you all able to see my mouse? Okay, so you see a lot of them are over here on the East Coast, not too far north, but here on the East Coast. Some in the West Coast, and then in the kind of the middle, but middle north, right? We don't have many in the South, don't have much here in the middle of the country as well. So still some growing to do. And it's actually interesting looking at this, thinking about where the applicants for our program come from. A lot of them are applying from countries that don't have them. Louisiana, Alabama, Georgia. We got a couple from Wyoming and Montana this year. So there's people throughout the country looking for this kind of support and help. Here are the main areas of focus for nurse practitioner programs. So you can see largely most of them, the bulk of them are general primary care, and then go into other specialties. Emergency room is really common, psych and like not only psychiatry, but psychology is also really common. Pediatrics, I know a couple palliative care ones, so it varies, but definitely the most are general primary care. So more research is needed to know if programs like this offer better outcomes than the on-the-job training that we get, well, that I got. And so can't really say one is definitely better than the other, but early data is suggesting that these postgraduate training programs definitely have positive outcomes on role transition and job satisfaction. And I also just want to posit here that I have seen many new graduate nurse practitioners join the workforce and be fine. Their competence matches their confidence. They are well-trained clinicians and they can handle that transition a-okay. But I've also seen many new nurse practitioners struggle with this change. And it's not that they don't know the information, but their competence doesn't match their confidence. And so that's why I think programs like this might be helpful. But I wanted to put that out there, that it's not an all or nothing. It's not a one size fits all kind of reality. But what are some benefits of having a program like this? So recruitment, right? A lot of the organizations that have these are looking for new grads or people who are wanting to change specialty and then wanting to keep these people that they've spent the year training. 95% of the programs in that same survey by Keston responded that this was a big benefit and that the NPs stay. Also increased nurse practitioner satisfaction. So if you're helping them manage the stress and learn the boundaries of the role as they come up, then they can therefore survive that first year with more grace and more comfort and be happier in their job. Enhanced clinical judgment, they're getting constant mentoring and teaching, increased competency and skill proficiency, their increased confidence, and then communication and collaboration within a team. So what's our program? The Keith Haring Nurse Practitioner Postgraduate Fellowship in LGBTQ Health. So Keith Haring was a pop artist in New York City who died of AIDS in 1990 and was a huge advocate for safe sex and AIDS awareness. When he knew he would be dying from AIDS, he started a foundation who manages all of his art and the clothing and whatnot that comes with his images, saying that all of the money that is made from any of his artwork in the future should be used on organizations, used to be given to organizations who are doing work to treat and AIDS and pediatric populations. He really loved kids, and he obviously wanted to do all that he could to prevent or stop end AIDS. Callen Lorde has a really great relationship with the Keith Haring Foundation. Obviously, they're neighbors. They're here in New York City with us. They often will donate things to our benefits and our fundraisers. And so when we found out about these programs in around 2017, and we were seeking funding sources, we actually sent a proposal to the Keith Haring Foundation saying, this is what we want to do. This is the kind of program we want to start. Do you think that you'd be willing to back us? And they loved the idea so much that they sent our proposal back with a few questions and suggested edits, among which they recommended we more than double our ask. So it went from they actually gave us the largest endowment in Callen Lorde history of $2.5 million for this program. So why are we doing it though, besides that we have the funds to do it? What is our drive? Callen Lorde believes strongly increasing access to LGBTQ health, not just in New York City, not just for our patients that are coming to our building, but to everyone in the country, if not world, right? We work with lots of international people, and we think that it's really important for people to remember that this 4% of American adults identifying as LGBTQ is totally underreported, and that any provider working within the US is going to have access to LGBTQ community members. There's several national calls to increase LGBTQ competent health care training. And it was also a Healthy People 2020 goal, which we were happy to support and try to make happen. Some more points to this, and I mean, I think a lot of the people in this room know these statistics, unfortunately, is that 50% of LGBTQ people face discrimination while seeking medical care. 20% of transgender people are refused care outright, not even allowed in the building. And now we even have laws that are making that even worse. And 42% of trans women actually report being abused and assaulted in their healthcare setting, which is meant to be one of the safest rooms you walk into. It's just not okay. And why is that? When you look at how much training happens in medical programs, and this is nursing, physician, physician assistant, it's on average, well, it's 1 to 42 hours of training, with the average being 5 hours of training in LGBTQ specific healthcare. So you're getting all of these years of training, and in 5 hours, you're supposed to learn how to take care of multiple communities that are diverse and full of these intricacies and specific needs. It's just inadequate. In one specific survey of nurses, it was Brown et al. Was asking, why are these nurses uncomfortable? Why are these nursing students uncomfortable taking care of LGBTQ communities? The main reports from these nurses were that they just can't recognize that these communities would need anything special in their healthcare. They don't understand the terminology. They just don't really get it. And they're not trained in areas such as PrEP, PEP, vaccines that are needed for people living with HIV. It's just not even something taught in their curriculum, so they're not even aware of it. For our first cohort of applicants, so in 2019, when we were looking at applications for our 2020 cohort, we got 70 people opened the application, 37 people completed the application. And we were really interested in wondering what these people are looking for. What is it that they really want? Why do they want to come to us? Why do they want to learn these things? What's going on for them? So we had, the majority of that year were from New York, and there were 17 other states also included in the applications. From all over, Texas, Alabama, Wyoming, California, all over the country. 43% of the applicants cited having no or very limited LGBTQ training in their programs, and they really wanted to be able to offer gender-affirming care, HIV management, and sexual health. They talk about, we had them write 3 essays, and in these essays, they were citing values such as wanting to alleviate LGBTQ disparities, really offer patient-centered care that's high quality, and their strong beliefs in making healthcare more accessible, which I think is are really common values for many people who go into primary care. But to think that they feel that they can't offer those things because these communities are LGBTQ plus is really heartbreaking. And so what it leads us to believe is that graduates from nurse practitioner programs are seeking further training, and they're dissatisfied with the amount of LGBTQ related curriculum that they have in their programs. So I wanted to go in a little bit about what our program looks like, what the setup is, in case this is your first time ever hearing about nurse practitioner residencies or fellowships. I just want to kind of go into some of the bones so that you can kind of understand about how we're doing it. So for example, this is what the fellows' weekly schedule looks like. So they have 4 preceptors that they work with all year. They have 1 session with each preceptor, Marcus, Aviva, Rona, and Dan. And that is for the entire time they're here. That will never change. It doesn't matter how competent or comfortable or routine these patient visits get. They'll have that person with them the entire time, and they can also send them messages when they're not with them on sessions. And we chose people that are true LGBTQ healthcare champions. So Marcus is actually the director of our sexual health clinic. Aviva is our person in charge of quality improvement for our patients living with HIV. Dan actually, Dan was a country doc in the middle of the country who created an HIV testing lab in a closet in his private practice because he wanted to be able to test his patients as soon as he heard that this was a problem happening way back when. He's a powerhouse and just somebody everybody needs to know. And Rona is our HIV clinical lead, who's actually one of the people who writes the guidelines for HIV management and PrEP and PEP management for New York State. Then they have 3 independent sessions, these yellow sessions. So they have time in the week where they're meant to become more autonomous and build those skills. Of course, there's always people around for them to check in with. And then 1 day a week is the specialty day. And that's when I set up time for them to go and shadow our director of anal health. Or I send them to a surgeon that does gender affirming care in New York City to go shadow. When I have them shadow me for doing gen care, we call it gen instead of GYN because everybody has genitals, but not everybody with a cervix believes that they need to see a gynecologist or has to see a gynecologist. So we call it gen care. And that's where they start learning how to do more affirming PAPs and other things like that. So that day is always spent on something more specific area of LGBTQ care. And they have a variety of meetings every single week. So every Monday from 1 to 2, they meet with our director of trans care services to do case conferencing and talk about what's going on in trans care. Every Tuesday is a provider meeting. Every Wednesday, they have an hour dedicated to HIV learning. And every Friday, we talk about some other aspect of care. So we could talk about menopause management. We can talk about birth control for TGNB folks. We can talk about metabolic management. We believe that people are healthy at every size, but how can we help people who are wanting to lose weight? All these different topics that can come up. And so this is their schedule for the whole year. And then their ramp up is really slow. To a lot of admin, this can feel a little like we're dragging our feet, but it is so important. If ever you start a program like this or are participating in a program like this, put your heels in, dig deep, and keep this slow ramp up. If you take it real slow in the beginning, 1 patient per hour, 7 patients a day, and slowly ramp up, what happens is you're really solidifying the good habits. You're really getting rid of the fear, teaching the information so solidly that by the time they're up to 20 patients a day or 24 patients a day, what was scary and hard is now routine, and they're confident in it in a way that's much more successful. So what do our fellows say to us now that we're 6 months in? Well, of those Friday didactics that I was mentioning, the menopause and contraception for TGNB folks, they like 91% of them, which is pretty good. I'll take that. You don't have to love everything we talk about. Every specialty day has been evaluated the highest possible, a 5. They really love their preceptors. That every one of them, the fellows think every preceptor is amazing. There was one fellow who was disappointed when they came in one day and saw that the preceptor was working with another fellow and like really wanted to ask their question. And so they were afraid. They commented that they wish they had been able to talk to that preceptor at that time, but it's understandable. They were working with somebody else. I have them do a reflective journal entry every week, meant to give them time to think about the things that really went well, potentially didn't go well, as they're learning and as they're developing. And it's really amazing to see. They don't always love it. They think sometimes they don't know what to write. But as somebody who's reading it on the other end, and I'm the only person who reads it, it's confidential. It's every single week you see this growth and this new realization of like, oh, I'm doing it. I've got this. I remember when that was hard. And it actually is really lovely to see. What do the preceptors think? So the preceptors tend to rate the fellows at a higher competency than the fellows rate themselves, right? So we have the fellows and the preceptors evaluate themselves. And so the fellows will say that I still feel like a beginner, but the preceptors will say you're actually very competent, which is not surprising to me that the fellows don't have competence yet, but it's an end of year goal. Even though the fellows are really very different, so far in this program, we've really been able to keep their understanding and learning parallel, which has been great. And they've gotten a ton better at using technology, not only to look up guidelines, but to help treat their patients and finding things that are helpful for their patients and learning tools. And unfortunately, weakness is still skills. Getting them the opportunity to practice doing biopsies, INDs, LARCs, that's still tricky, especially this year in a new clinic during COVID. I think this is just really interesting and could be interesting to all of you. These are the top 10 diagnoses that they've made in their patient visits in the past 6 months. I really think it's a very interesting snapshot of the things that are happening for our communities right now, and the kind of things that are really basic and often seen within LGBTQ care that you might not see as much in other FQHCs. So now that you've heard me talk about this and sing its praises and it's so wonderful, how do you start your own? It takes time, right? I feel so lucky that Callen Lorde had the foresight that they wanted to have a program like this with the opening of the Brooklyn Callen Lorde Clinic. It doesn't happen that way for everybody. Lots of people say, okay, you have 2 months, you have fellows coming in, make this happen. What are some things that you need to do to make this successful? Obviously, identify your key stakeholders and funding and start working on those right away. Develop the characteristics of what you want your graduates to be, where you want them to, like what you aim for, right? What is it the goal that you're achieving? For us, it's that we train people who can take all of this knowledge and bring it forward, like ripple effect, spread the information and train others. Make sure that you communicate with your team all the time, not just the fellows, but with the preceptors, and consistent mentoring, not only for the fellows, but for the preceptors. Everybody in the team has to keep learning together. Everybody's new and doing this for the first time. Evidence-based competency assessment tools are tough, right? Programs like this, well, in LGBTQ health, specifically for nurse practitioners, doesn't exist. So feel free to reach out, ask what we used, ask what our tools look like, and then definitely think about how you want to measure and the data metrics. I really think standardization is important. I think it's really easy to call a program you have a training program or, you know, a study, a research study, and until you really bring it down to the nuts and bolts to make sure it's got everything it absolutely needs, that's standard, evaluated, evidence-based, you can't really guarantee that you're offering quality. And especially for LGBTQ communities, why do we want to continue offering something that's not quality? It's been a long enough history of that. So these are some of the groups that you can get standardization through. The National Nurse Practitioner Residency and Fellowship Training Consortium is a group that was started by Margaret Flinter, the creator of the very first program ever. So it has the longest history of understanding these programs, creating these programs, monitoring these programs. Hence why it's the most popular. It's also the one that we're applying for accreditation through. But there are others. There's NOMF, there's the Veterans Administration Center, there's American Nurse Credentialing Center. So you can pick whichever one you want. What I like about these top two is that it's based on postgraduate competencies much more clearly than, say, the American Nurse Credentialing Center, which it seems a little bit more nursing and still learning based. So again, why get standardized? To protect your healthcare consumers, to protect your patients, to make sure that your fellows or residents are learning in an evidence-based and high quality way, and to address the lack of consistency in national competencies, right? So especially for nurse practitioners in LGBTQ health, there are no national competencies. So if we can do these things to standardize, we can create some ourselves. A lot of people will say, but I don't have the time or the money. Our organization is like already suffering. Everybody's overwhelmed. These are all true. Okay, I understand that this program takes money, affects a budget. I know that somebody has to be dedicated to putting time into it. I think that if you can just sit with each of these and just take some time, there's always ways to be creative, but I do understand. I think that these are perceived barriers, that it's not impossible, but I do get that these are things that will make it harder and that you need to think about. A big thing about funding and support on how to make it happen are these three organizations. So the Weizmann Institute is another institute that came out of Margaret Flinter and the consortium, and it's all about improving primary care, changing primary care, innovating primary care. in a variety of ways, not just nurse practitioner postgraduate programs. HRSA has now started giving loans to programs who want to do programs like this. So if you apply to HRSA for a loan or a grant for these programs, last year they did over $2 million in this grant money, and you have the 2 years to get your program up and running and show that you're using the money for the way that they want. And so then that's not money from your organization, it's from HRSA. And then, as I mentioned before, the National Nurse Practitioner Consortium is an amazing organization. It's the kind of group that if you have a question or you need some help, you reach out to them and they get back to you within like a day or two. They will share all of their resources with you. They do a meeting, an annual conference every year. Highly, highly recommend. Even if you're just thinking about it, take a look in these 3 groups. And that's really the main part of what I had to say. Any questions?
Thank you, Catherine. And if folks want to, if in terms of absorbing all that amazing information about this program, if it didn't come through clearly, as a nurse practitioner myself, this is an unprecedented novel program that was so well funded and recognized for its value for nurse practitioners in our profession. So please put some questions or be open to discussion in the chat if you would like. I think one of the questions that I have for you, Catherine, and this is in the first year, was with regards to the foundation itself and the expectations of the foundation in terms of sort of performance, and what did Keith Haring Foundation expect of you in terms of like, what did you put your, John Hancock on, right? What's the deliverable? So it's not just the program, but like, what was their expectation? I'm curious for the $2.5 million.
Yeah, and we are not using all 2.5. We decided that Callen Lorde would take that and create a program where that money is housed, and whenever we start a program that's based on increasing education in LGBTQ health, we'll take from that endowment. Mm-hmm. We obviously are not using all of that money, but really the deliverable, the promise, if you will, is that we would train providers who are passionate in LGBTQ health and HIV AIDS management, who will then carry it forward, right? So we explain to them that we don't have access to this training in school, and there's this serious dearth of LGBTQ competent providers within the US. And they're like, yeah, we hear that, but what are you going to do when it becomes available in school and it's a normal part of training? Like, then will this program still be needed? And we're like, it will be, right? Because we need to find places where people can practice and still learn hands-on experience. But it was really mainly that we take this person who's passionate about LGBTQ health and kind of turn them into an LGBTQ health champion, not just clinician, right? So a big part of the fellowship focuses on what happens outside of the exam room. Inside the exam room is really important, and we work on that all year, but we also, throughout the year, they have to do an advocacy day, they have to do a QI project, they have to work on a research project, they actually have to attend 3 LGBTQ sensitivity trainings and then host 1 or 2. They have to do interdepartmental teachings on LGBTQ health related topics, train other fellows in other programs. It's all about teaching them how to take this knowledge and really comfortably disseminate it across the board, whether it be to other professionals, to other learners, all over.
Thank you. So there's a question that came in through the chat from Christian, and maybe you could speak to this or also email directly. Speak a little bit more about the evidence-based competency assessments and what resources do you use to develop those?
Yeah, really great question, Christian. So what we did is actually the consortium had an example of a competency assessment tool that they created for their fellowship based in primary care. And we took that and then went to the organizations we use for our guidelines. So the New York State AIDS Foundation, and we went to for anal health. I can't remember the full name of the group, but like, so all of our clinical guidelines come from different organizations. And I just went through to what those organizations are and what our clinical guidelines are, and then created it based off of that. but there's not like a group of nurse practitioner educators that have put this forward. So I just went to the organizations themselves and pieced together what I could, which is unfortunate. That's not like the best that I want for this, but it's what we have right now. And until more people do this, and until we can have working groups putting these things together, that's kind of what I have access to.
I'm thinking in terms of anal health, and probably Will still the director of anal health at Callen Lorde.
Yeah.
There's ASCCP that does, our guidelines around colposcopy and primary HPV screening. But some of these things, I think you probably would agree, Catherine, don't exist even in terms of national guidelines. And so we have to turn to, Callen Lorde is actually one of the organizations that develops some best practices that get shared with other folks. And there's like UCSF, of course, and the Center for Transgender Excellence, there's Fenway, but some of this doesn't exist. So even in terms of nurse practitioner education and training, you have to work with what you have.
Yeah, but always making sure that something's based in evidence or from a group, like the highest level of evidence that we can get, always that.
Absolutely. JP, did you have a question?
Yeah, thank you so much. Excellent work in building infrastructure and building our nursing workforce. How do you foresee disseminating curriculum, teaching materials, best practices? I mean, you're co-leading in this effort. There's not many centers of LGBT excellence, right? So not only are you creating something unique for that cohort, but then also for hospitals, right? And clinics and academic health centers. So what are you hoping for in terms of disseminating not only like outcomes-based papers, but just the curricula and teaching materials?
Yeah, great question. Thanks for asking. It's in, we hope to create like a white paper, like a how-to guide at some point. Haven't gotten there yet, but really taking this first year to solidify the curriculum and like really type it up and figure out where our weak spots are and then try to plug those. And then next year, we're really focusing on accreditation. And then I kind of have after that, like, okay, right? So currently what I'm doing is presenting, and then anybody who ever has any questions, for example, Fenway recently contacted us because they want to do a program like this. And so we're here and happy to help. So really, I'm just sharing through emails right now and presentations, but it is a goal to create some kind of publication, some kind of print up for other people.
So Anthony knows what I'm going to say, that not to give you more work, but just to mention an opportunity to disseminate. I'm a big proponent. I think, Dr. Potter, Jennifer Potter from Harvard, and other individuals that worked with the AAMC to put out that white paper on how to build climate and curricula at our academic health centers. They also went on to publish many of their teaching materials in this journal called Medit Portal of the AAMC. Now, has it historically been recognized as a medical and dental education journal? Yes, but they're open to nursing material.
Mm-hmm.
Like, they will be fair. They want to be inclusive. You can publish your teaching materials to teach nurses, nurse practitioners, the entire workforce. So just consider that. It is open access. So there's always this fear that if it's open access, can you still charge? You can. That's a separate question, but I would encourage you to consider that, because I think what you're doing will benefit many. And there is this opportunity, and it's PubMed indexed, it's peer reviewed. So you will get credit, you get full credit. So Anthony, you knew that was coming, huh?
Yeah, I can give you the reference, and we've talked about this in the past, Catherine. I think something that I think a lot about as you were talking, as someone who has been in nursing academia for many years as well, is that we are a little bit backwards in nursing. We're a lot backwards in nursing, quite frankly, in terms of LGBTQ health. To some extent, there is sort of like the clinicians like ourselves that are like working clinicians doing the work. And then there's the folks that are actually with the AACN, like the American Association of Colleges and Nursing. There's AANP, which is a professional organization, but I'm thinking more on the academic side, that there's some resistance, like it's their ways, it's the old ways. And so, and an understanding even, as you mentioned, and I'm so glad that you address this, Catherine, that not everyone's on board with the concept of a fellowship or a residency program. And to be clear, Catherine and I were trained in sort of like the old model, if you will, which was you get your NP license and you graduate from school and you find a job. And you hope that it's a place that will be patient with you, because we have no residency. We're literally thrown into the very deep end and expected to earn our keep very quickly. PAs are not trained this way. And obviously medical doctors are not trained this way. So it's a shift in culture. And I wonder what you think about that. How much of this do you have to sort of like contend with the old sort of nursing academic culture to get the validation, to really say like, these programs are really, really important? Or are they just going to say, this is really niche, Catherine, like what you're doing is really, it's so niche. Okay, whatever. It's like, whatever. But really what this should be is like wider, much, much wider.
Yeah. I think that when it comes to a postgraduate training program, I get a lot of, oh, well, that makes sense that you need that because, right, you're talking about a topic that's like very specific. And then I turn it on the head that I shouldn't have to be talking about a topic that's very specific. And so really, I always try to highlight what our applicants are looking for and why we need these programs. And it's because the training isn't available in our programs, in our schools, right? And until these are board certified topics, it's not going to be, right? That's the impotence that we need, is that these topics be on the boards and therefore required but in the curriculums. And then hopefully this will be like any other postgraduate training program. But that's kind of what I try to use it as a way to bring up the topic of increasing the scope of our training.
Mm-hmm. Yeah, there's this famous article that I think that you were alluding to, by Juno Obenamalaber, my mentor now at Stanford. And it was published in JAMA many years ago, now it feels like, and that it was basically, what is the percent of time or of medical school education that's spent on any kind of LGBTQ health content? And it's very little, is what and they assessed all of North America and Canada. We have not done that assessment actually for nursing. And as well as I know, if you went across the board, even in 2021, it's probably worse than med school. I hate to say that. It's like, we're not there. We just don't have the empiric data. Maybe one day we will collaborate on a paper to do that work. But yes, I think your example and JP is right. Like your example needs to be published so that as many people as possible are aware of this, so that they can replicate it. And this is like the perfect first start. And of course, yes, it is your first year. So you're allowed a year to figure that out. But there's people out here that will, help as much as possible. And maybe there's a book in this too, or maybe there's beyond a white paper, there's something in this to kind of like extend it. I'm just trying to think of like the nursing organizations that will validate you even more. Right. So it's like, who are the most important nursing organizations? And the problem with the nursing, for folks that don't know, is nursing is very fragmented in our function and role, and especially advanced practice nurses versus bedside RNs, and sort of like the education around that and the thinking around that. It fractures us even more. So it's very frustrating.
Yeah. If we're thinking strictly nursing, there's such a need for community health nursing and there's primary care, but it's still so hospital focused that I recently did a presentation to the National Student Nurses Association, and I was just really, it was about LGBTQ healthcare and nurses working in LGBTQ healthcare, and I just like plugged that we need you in the community health centers. I know that it's sexy in the hospitals and like that's what everybody's like first image of the nurse is, but actually we need you here more,
Yeah, I think that's reflective even in medical school education. When you look at residency training, and JP, you probably would agree with me, when they look at when you look at training of doctors and the time that they spend in the hospital versus spent in the ambulatory environment, it's a lot of hospital medicine. And part of it is a perverse incentive around, it's about money. And sadly, I have to tell you, I mean, you probably agree with me, like in terms of Catherine, like nurses train, and it's like, as you say, it's sexy, but it's also, you know,
I know.
education is expensive and you want the golden bucket at the end of it. But there are people that are very, very passionate about community health. It's just the schools aren't. So they're not incenting people the right way either. Oh, thank you, Matthew, for agreeing with me. And Catherine, so Matthew says, at some point, I'm at the Center for Sexual and Gender Minority Health at UCSF, and we did an internal curriculum analysis for the School of Nursing, and there was around 1 to 2 hours as an elective for nursing students in LGBTQ plus health topics. And that's at UCSF, which is a fabulous, UCSF has the Center for Transgender Excellence. I mean, it's like, come on. So you can wonder, I actually just did a lecture for Indiana University, Fort Wayne, a colleague of mine, and they told me that my lecture was the only content that they have ever received. So, and it was 45 minutes. So
when I was in school, I had 1 lecture. That was it. I was like, oh,
Yeah.
look at that.
yeah,
I mean, like, so on the slide that I had previously, the 1 to 42 hours was actually Saccone did a review of over 1,000 articles across the specialties of training, and the average was 5 hours of training in a program.
Mhm.
So
That sounds about right.
you're a
That
little
sounds
bit
about right.
below average UCSF, but I have faith you can bring it up.
Yeah. So we just have really just a couple of minutes left here. Are there any other questions for Catherine with regards to this fabulous program? And I'm getting my 3-minute reminder. Thank you. And here's the next link. So if you can see everyone, where we need to go next is where ABM's iPad is linking us into. Because we've been having some trouble with Zoom links, and I appreciate everyone's patience. I want to thank Catherine for your hard and good work of many years, quite frankly, in terms of community health. But the culmination of that, I can't think of anyone, quite frankly, that is better qualified to lead this program at Callen Lorde, my former home and family. I'm just so excited to see what you're going to be able to do with this. And I remember meeting your fellows right at the beginning, and to see what seeds they're going to, what trees they're going to grow in their own communities in the future, and the leaders that you're building for queer health. So excited. And we hope that you will come back and tell us more about the progress in the future.
I would love to. Thank you all so much. And please email me with any questions, any thoughts, even if
Yes.
you're interested in working with some of the fellows. I love creating connections like that. I'm happy to do even a fellow resident swap, can shadow each other. I think there's a lot to learn in coming to a clinic that is so LGBTQ focused, for people who are interested in LGBTQ care, to see how we do it. Or if are you working an interesting thing that you think it would be good for these people to know? I'm totally open and happy to collaborate.
Yes, Catherine has curated some really fabulous fellows, and the next cohort is coming in.
I would just
You just have 3 this time, right? So we had 2 in the first year, and then 3 is coming in. So there's going to be some more fabulous people. So thank you again, Catherine, for spending the time to share your wonderful progress in this program. Catherine's email is Chisello with double S and double L at callen-lorde with an e.org. So please, 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 please follow up if you need to. Is this correct? Did we do this wrong? No, it's correct. Okay, we're good. So in terms of the next place that we're going to be going, if everyone can copy that Zoom link that you see here, it's the one that says, "Hi, Anthony, I wanted to give you," oh, no, I'm sorry. You guys can't see this. Let me actually paste this in. This is where we need to go next. I'm sorry. If there's confusion, this is where we're going next, because the links have been a little wonky today. I apologize for that, and I appreciate everyone's patience, and I appreciate, Catherine, everything that you've done and will continue to do.
Bye.
Thank you.
Thank you.
We'll see you in the next place, and I'll see you soon, Catherine. Okay, I'm gonna click on this guy.
Anthony, I thought this same link was for.
Are we in the
Untitled
same place?
Chapter,
Yes,
right?
you know what? It's the same place. I
Yeah.
don't know.
I think it's.
Because I just clicked on it.
I
Wait, let
also
me see.
didn't understand why the link wasn't working. Was it clear? when
No,
you-
I don't really know. I had to talk to Nelson about this later. It has to do with, well, there were two different issues. One is like we've set up waiting rooms which you shouldn't have, and people should just be able to enter. And then I think it was like one of the rooms was wrong and the other room was right. So
Okay.
people were going to the wrong place.
Okay.
But I don't
now
know
we
why
are-
though.
We are going to 3:15 and we're going to prep. Is it? That's an.
Yes, so there's a prep one that's called,
Is there more than one?
well, we have a prep presentation tomorrow as well, not today.
Oh, okay.
There's two different prep presentations, but one of them's tomorrow that I'm moderating. And
Okay.
then the one today is different. So the one that's at 3:15 is improving HIV pre-exposure prophylaxis and equity for sexual and gender minority people. And let me just look at the numbers because I can compare the URL number.
That's
It should 47966. Yes, so that is this room, I believe.
Yeah.
no.
Anthony, I clicked the link and it brought me back to this room.
Yes, so I think it's this room. I don't know why.
Why isn't it 2770?
That's a good
Like-
question.
In the program,
No, but it is. So it's 2770 in this link that I shared with everyone. And it's 2770 in the program.
okay, yeah.
It's,
So
we're consistent.
one
We're in the
can
right
be
place.
here.
So the
I'm fine
problem
with
is though, like when we have these rooms going like this, I thought that people can come back in, but the error message that I was receiving and my presenter was receiving was the meeting is already in progress, so you can't enter. And that was the problem. So I don't know why that happens, but we'll find out from Nelson and we may have to update the
Yeah.
program tonight.
But we're all going over there now, right?
But we are there, I think.
We are there. Yeah, we are there.
This is the room. So
Because I
what-
left this and came back to it using the link.
I actually think what I should, okay, so you came
No,
back.
we're
You,
joining a new meeting. I'm leaving you guys.
Okay.
I'm joining the other one. Bye.
okay, bye. I'm gonna actually end out this one. We need to close out this one. So everyone that's in this room, Nancy and whoever is dialed in needs to actually leave this one to be able to go to the next one. So if you could do that, that would be great. Just make sure everyone is exiting this room because I do not have the ability to close this one out. So let me just tell Nelson.